started. It's 11, just after. Welcome to our November WPCC meeting. It's the first meeting that Peter took off and made me be pilot. So bear with me as I continue learning this role. Let's go ahead and do roll call. We'll start with those in the room and then we'll head to those on the phone. And do you want to start, Linda?
Sure. Linda Parlett, Executive Director, North Central ACA.
Mike Lopez, Granite Services.
Jill Thompson, Lakeline Clinic.
Chris Devillanu, Catholic Charities.
Rosalinda King, Columbia Basin Family Medicine, Ada.
Jim Novelli, Okanagan Behavioral Healthcare.
Edwards, Columbia Valley Community Health.
Elisa Vanek, Children's Home Society.
Dave Foldy, Confluence.
Karen Jacobson, Family Health Center.
Melody White, Family Health Centers.
Roger Chapournier, I'm part of the consulting team.
Dulce Field, CBHA.
Paul Hadley, Center for Alcohol and Drug Treatment.
Deb Miller, Action Health Partners. Caroline Tillier, North Central ACH.
I'm Wendy Bresney, for those who don't know. Want to go ahead, Chris?
Sure. Catholic Charities. Susan Martin, Catholic Charities. Shively Grove, Catholic Charities. Knox, Wallace Hill.
All right, how about those on the phone?
Good morning, this is Rachel, PSS.
Morning, Rachel.
Hi, this is Shoshana Palmentier, Cooley Medical Center.
Morning.
Grant Integrated.
Ramona Hicks, Cooley Medical Center.
Christina Clark, CCMI, part of the consulting team.
Courtney Fairbanks with the Children's Home Society.
Doug Wilson from Confluence.
Kathy Rhymes from CSI Consulting.
Tracy Miller, Mid-Valley Clinic and Hospital.
Anyone else?
See Kim Fricky from Moses Lake. Did he announce himself?
Kim from Moses Lake Community Health, are you there? I think we see you online.
Can you hear me okay?
I can now.
All right, thank you.
Anyone else we're missing? Hey, you guys have I didn't print the minutes. Well, we will not be approving the minutes because I did not print them. But you do have the agenda in front of you. See, this is where PETA would have said, where are your minutes, Wendy? So you have the agenda before you. I think we need to approve it. Do I have a motion?
Make a motion to approve the minutes.
Second by Dr. Coldy. In favor? All opposed? All right. Let's dive in so we can get on to Roger's talk. The first thing we wanted to, we have the announcements. Just wanted to give you guys an update that the coaching network, you've heard us talk about coaches for quite some time. And we've currently been staffing coaches with our faculty, our consultants. We've decided to move forward with requesting from the board to hire 2 new staff at the NCACH, which will be coaches for our Learning Collaborative, for our funded partners. These individuals will provide much more time than the consultants will be, and they'll be integrated into your clinics as much or as little as you like. So they would be full-time individuals if we get the board approval, and they will be local. So they will be able to assist as needed, either in person, virtual, or via phone as the Learning Collaborative, for the needs of the Learning Collaborative. So we are seeking board approval today, and further information will follow once we have feedback from the board. With that, we are presenting the budget. Majority of the budget is going towards the Learning Collaborative in funding the learning activities as well as the participation for those activities. So I'll show you that calendar later, what we have in store, what we're looking forward to in 2019. Next screen. There was a request by the Learning Collaborative on social determinants of health. I think individuals are saying, are there any screening tools you recommend? And they are not necessarily recommended, but there are some tools that were recommended. We are actually recommended that you look at topics. Community health's not here. You can take their seat. There are certain core topics that we're asking you to look at. I know a lot of you already have topics already ingrained in your questionnaires that you're already asking. So just kind of these topics, we just make sure you have them all covered and the questions that you're currently asking.
And we'll post a resource to the portal ideally this week. We ran it by the WPCC work group, and the work group asked us to cross-tab some of the screening tool questions with what the Pathways Hub asks. So we're going to add that in and then post it to the portal. So hopefully you'll find that useful.
Click it once. These are the tools that have been recommended by those within the collaborative who are others who are using certain tools. These 3 rows to the top. Click one more time. We just want to make sure that we are not requiring any specific tool. We're just requesting that you cover all the different core topics. As you know, healthcare authorities getting ready for value-based payment. In the toolkit, there are a few resources. We just wanted to share them with you. The first one is the JSI, sorry, I forget the name of it, Payment Reform Readiness. It's a website that has a tool that you can go, it's an assessment that you can use to look at payment reform. Next one is from the American Medical Association. It's another value-based tool. Again, you can look and see which one's right for your clinic if you're needing more assistance to move forward with that. And the final one that has been recommended in the HCA toolkit is with the Rural Health Value Team's Comprehensive Value-Based Care Strategic Planning. And it's a toolkit that has all the resources that will guide you towards value-based payment, moving your clinic towards that. So I just wanted to share that information out to you. I did upload them to the portal. If you go to the portal and you look at documents, there's a folder that will be value-based payments, and that's where they're uploaded. If you have specific tools that you have found helpful as you're moving towards value-based payment and you think that others could think they're helpful as well, feel free to upload those. Just click on that blue rectangle on the upper right that says folder actions. Learning activities. Did you guys grab the long sheet? 2019, the learning activities are divided by the different sections of the change plan just to make it a little easier. These are proposed, a couple of them confirmed, and I will go through those in just a minute, but these are when we had a strategic planning meeting with the consultants based on feedback from the kickoff meeting and feedback we've received from the consultants and the coaches. These are some of the ones we're looking at. So I just wanted you to have a calendar. I'm not going to go through them right now, but if you have feedback or want any more information, feel free to just email me or give me a call.
And Wendy, it might evolve, right? The calendar, like
yes,
like
it's just
current thinking.
Yeah. These are proposed. If as our coaches move forward or as we continue with the meetings and other needs arise and we feel like they're more priority than what's on the calendar, we may substitute something out on the calendar and add something additional. But you will be updated along the way if that were to occur. There are 3 trainings that are coming up. The first one is empanelment. It starts December 7th. It's a sprint. It's weekly for 9 weeks, excluding December 21st and December 28th. Roger, do you want to speak a little bit about that one?
Sure. One of the fundamental pieces of population management, being able to manage a population, is knowing what population is and handling your population to care teams. Easier said than done. Many organizations really struggle with empanelment. So this is, and part of our diagnostics where there were some organizations that don't impanel, they really focus on any willing provider that's available today to see the patient. So this impanelment is as I said, is a sprint. It's really designed for those that manage the panels and have to sustain them over time. So it's likely to be an administrative person. It's open to clinical people, but more than likely it will be an administrative person. It's designed primarily for primary care. Someone who just dialed in may so we'll be working through from the basics of understanding why impanelment to how to calculate the supply and demand calculations, how to risk adjust the panels, and then how to build sustainability over time. So it's, those are early stage of those that are struggling with panels.
Great. The second one we have is the Foundation for Motivational Interview. This is a train the trainer that's going to be offered in February. There is a application process that you have to go to. The faculty who did the introductory motivational interview have identified individuals who would be, that they think would be great going through this train the trainer, and they're reaching out for them. However, if this is something you have staff that would like to be trained the trainer for your facility and they meet the prerequisites and requirements, feel free to submit the application and it'll be reviewed by the faculty. And that's a 4-day skills-based workshop in here in Wenatchee starting in February. The final one is the cardiovascular sprint. That's going to come in January. We don't have a date set quite yet, but that should happen in the next couple weeks. And do you want to talk about that one?
So that obviously still in the late planning stage. I've talked to some of you in the room who are participating. This is intended to be really for more mature organizations in order to have a pretty robust quality improvement effort. It's designed to focus on cardiovascular disease, as noted. They'll be working through the measures based on the alignment with what fits the needs of the teams. Clearly, there's one CBD measure that is part of statewide portfolio and part of the person care collaborative, so that will be one of the measures. It'll be a very small number of measures. It's designed as a sprint for care teams, so this is the actual clinical lead as well as the other staff that are part of that care team. And it's really a working meeting, not a lecture series, but an opportunity to share best practices. There'll be some subspecialty support in terms of decision support, and all trying to drive these set of metrics over a relatively short period of time. So really designed to help groups accelerate their quality improvement work, learn how to collaborate across the environment with other organizations, and to share best practices in the region.
If this is something your facility is interested in, then just let me know. Go ahead.
We hope so, yes. They're the lead. We hope that they would thrive in this environment and find it beneficial.
So Wendy, you're saying we got to sign up with you?
If you let me know you're interested, I'll let you know when we'll have the registration. It's just not up yet, so I just don't want to miss anyone or miss it coming through the announcements.
And we're going to propose an introductory call to get folks together and talk through the measures, and then what time will this fit in terms of clinical flow. So it's likely to be early in the morning or lunch at the end of the day. It's not intended not to disrupt the clinical flow. So we'll be there to support that.
Any other questions on CBD? You had a question on your chat?
Yeah, so Roger, Gail is asking about the impanelment in primary care sprint. She's wondering if behavioral health providers can participate or whether they would get value added if they participated.
I think they could participate. Most of the orientation is around primary care. A lot of the calculations for supply and demand, the principles apply across the board, but it's really designed more for the primary care side. If there's interest on the impanelment on the behavioral health, that's something we might be able to explore. They're welcome to sit in, but otherwise we could explore that as a separate potential offer.
So what I'm hearing you say is that it's really not designed for behavioral health.
It's not designed for behavioral health. The care team mix is different,
Okay.
and the supply and demand is very very different in that environment. So it's much more oriented towards primary care.
But I think from the behavioral health standpoint, though, I think somebody, for me specifically, I think I would like to understand that concept a little more, because if it's something that we can take or pieces we can take, I would certainly like to know more.
Welcome to sit in and participate.
Any questions on any of the upcoming learning activities that have been scheduled or proposed? Okay.
And Kathy on the phone is just chiming in that we do want to have another empanelment learning activity geared to behavioral health.
Okay.
Later in the year.
I can wait.
Thanks, Kathy. All right, our current Learning in Action networks, we've had a fantastic participation rate, not just that the fact that we have 11 organizations, primary care organizations, and 7 behavioral health organizations participating, but the number of individuals who are on these calls every other week, as well as the homework that's being turned in. So I did want to get some faculty feedback. I know some of you sit on these, but many of you don't. So can you give a little bit of feedback or from your perspective, and then we'll have Tina from hers.
Sure. This is Kathy. And I agree with Wendy. We have a great group, a very diverse group. As many of you know, a lot of the teams have chosen their project to work on, and many of them have chosen depression to focus on. So they're working on screening and follow-up, really thinking through the steps. There has been really great engagement at the learning activity and doing the homework. Some of the other folks, just the topics that are coming up. One team is working on complex care patients, making sure that they receive integrated services. We've got a team working on SBIRT. We've got a team working on helping behavioral health and primary care team members communicate, and hoping that there is less emergency department visits because of that enhanced communication. And then we've got a team that is working on behavioral health services for pediatric patients. And what we're doing in the learning activity is walking people through the steps of creating what is really a good quality improvement project. So thinking about what it is that they want to accomplish, how are they going to know that they've made those improvements, and then we're providing faculty expertise to walk them through some change ideas that they can take back to their practice. I think the participants have been very positive about their opportunity to talk with each other. We're utilizing the Zoom breakout rooms, so it's a very dynamic group. We try to match people up so that they have a bit of time to talk with each other. And then we're always asking for what can faculty do, what kind of information do you need? So a very broad brush that goes across the spectrum and just really should align with and meet the need in the region. The other thing we're planning is a touch base call after this next session, just to see where people are, and we recognize it's impossible to meet everyone's needs on these calls because they are diverse in what they need. So we'll have a one-on-one call to hopefully get some information. And then our final call in this session will be to have a psychiatrist to answer any questions about telepsychiatry or how a psychiatrist can be involved, or I know many of you have questions about how to engage psychiatry or how to really leverage their expertise, especially with the psychiatric shortage in the area. So my email is plastered everywhere, so if any of you in the room have any feedback for us, or if you need something from us that you feel like your teams haven't received, please reach out. We really do want to meet your needs, and we really appreciate the excellent participation and sharing that's been going on to date. Any questions for me right now?
seem like it, Kathy. Kathy's leaning the primary care organization land at the moment. And Tina, are you available to talk about the behavioral health?
You bet. Yeah, and I'd just start by echoing Kathy's comments about any feedback as it comes up along the way. Reach out anytime. I think my email is also plastered everywhere, so don't hesitate to reach out to me. So I'm subbing in today because our lovely faculty, Sarah, John Kern, and Connie Davis are each committed elsewhere today. So we've had, and a number of you in the room have been participating in this. We've had about 3 sessions to date, which started on the 3rd of October. There's 37 unique registrants at the start of it. And remarks from faculty are that they've been really thrilled with the diversity of participants and the extent and quality of the participation in the lands in terms of sharing the bright spots in your own organization and helping to spread that learning across each of the sites. So as on the slide, there's 7 organizations that signed up: Catholic Charities, Children's Home Society, Columbia Valley Community Health, Confluence, Grant Integrated Okanagan Behavioral Healthcare, and the Center for Drug and Alcohol Treatment. Overall, the participation we've observed and the feedback we've been able to collect at the end of the sessions has been quite positive. But again, if you have feedback, if you have suggestions, we're always open to that. We're learning and trying to develop these as well as we go. So there's been a variety of different behavioral healthcare sites that have been able to share their bright spots, as I've mentioned, participate in that mutual learning and sharing. Each of the sites started by defining a project and working one-on-one in an orientation call with Sarah and John to talk about gaps and to talk about what's the one evidence-based behavioral health practice and defined population you want to start with. And so some of the project topics we've seen come up are on the portal, again, for others to take a look at and to share what each organization is working on. Some of the topics we've seen have been standing orders, including lab work, and or referral to primary care provider and substance use disorder providers as part of the nursing assessment registry process. Improving care for diabetic patients who have fasting blood glucose over 126, improving metabolic monitoring of patients prescribed atypical antipsychotic medications. So there's quite a diversity of different projects that teams are working on. And now, after the last session that we held last week, teams are starting to think about what are going to be their workflows and mapping those out. And Sarah wanted me to reiterate that, again, each of the sites has access to a practice coach to support that process. As she mentioned, it can be time consuming. So if you do need to lean on that support, don't hesitate to follow up with any one of us. Every door is the right door. That's all from me.
Did anyone have any questions for Tina? Great. What about feedback from those who are participating? Some of you are involved in the land. Do you want to give feedback on from your perspective? Should turn my microphone on for those on the phone. I'm sorry.
I think the support that the LAMS provides to our staff really helps them feel more confident in this new area for us. It's just been great. Being able to talk to other facilities about what they're doing and realizing that we all share a lot of the same concerns or problems and efforts in making sure that we're successful in this, I think so helpful. Really makes our work go far.
Anyone else?
Yeah, I want to second that. What I'm noticing is that these practices and meetings that we're having with your support have been really helpful team building practices. Like I feel like we're building a more solid team by having these work sessions together and bringing people together that don't normally work together on a regular basis. So it's really helpful.
And having the homework, having something like that common deadline that we're all working on together,
It's really stepped up that sense of urgency of this is not something we're talking about anymore. This is something that we are implementing. And I think for our organization, that's been a real game changer.
Any other feedback? All right, I will reiterate what Tina said about the portal. In the document section, there's a learning activities folder, and under that you'll find another bidirectional folder, which has both the integrating primary care and integrating behavioral health. All the homework is uploaded there, so if you are interested to know what others are doing, you can find it there on the portal. All right, work group activities. At our last work group, we had a conversation about communications. We just want to make sure that we are effective in the communication that we're giving. We learn from them, and we just want to confirm it with you guys that email is the best. We're trying to use the portal a lot. I think we'll continue to use email with links to the portal. So that's where we'll be posting the information, but we'll still try to use the email as well. The other is the information flow. You have a lot of different individuals coming at you. You have the NCACH staff, and you have the coaches, and then you have the land faculty. So we just want to reiterate that no door is the wrong door. You can call any of them. The information eventually gets back to the rest of us, or they'll direct you to the person who can answer your question. So is it confusing for you guys who to go to when you have a question? I guess not. Okay.
No.
No, not at all. When all else fails, if you don't know who, just email me. Because if I don't have the answer, I'll get the answer for you or send you to the person who has the answer. The other is I will be contacting you. I have found that when I need to send specific emails about, say, the leadership series or about change plans or about the coaching, I'm not always sure that I'm sending it to the right individuals within your organizations. So you'll get an email from me to follow up just to make sure I'm including the right people who need to be included on those emails. So there's a lot of different players with 17 organizations. So just want to make sure I'm contacting the right people and making good use of the time. The final thing I want to talk about before I hand it over to Roger is portal notifications. When we originally signed up, the portal notifications was turned off. You could manually go into your profile and turn those notifications in. Under my profile, I will say that we are starting to get those will automatically be turned on. So you go to my profile and then you click on the content notifications setting. And on the top portion, you can see the different areas that you can set your notification settings. At the bottom, once they're set, the bottom is where you'll see your settings and you can edit in either place. Coming soon, we're hoping today, if not tomorrow, everyone will be flipped on and you'll receive notifications once a week. So if you want to change those, then you can always go to this setting and change it. If you already have settings previously in the portal, it will not override those. So if you're on a daily setting, then it'll stay a daily setting. But if you're not on anything at all, you will start receiving them once a week. So we want you to be aware of that. Any questions? Okay. Without further ado, I will turn the rest of it over to Roger.
Great. Well, thank you, Wendy. Let me see if this, oops, that does not work. Okay. Let me create a bit of a breadcrumb trail from our last meeting. Those of you that will remember, again, I'm Roger Chaufinier. I'm one of the consulting teams supporting the collaborative. We had suggested as part of the design, one of the critical success factors in all improvement efforts is the role of leadership. And rather than starting a whole separate leadership track, that we weave leadership into this meeting with much more of an applied focus. The design was intended to, each time we meet, to introduce a little bit of leadership content in terms of sharing some best practices and what's working and things to remind you of as you help oversee your efforts in your organizations, and then put our energies on really design, where can we improve the environment. At the last meeting, we reviewed some of the data from the state in terms of how the 4-county region here compared to the rest of the environment. Identified 2 areas where we seem to perform in the rear, if you will, compared to the rest of the state. Our numbers are not as strong as others. So one was in the area of asthma. The other 2 were follow-up post-discharge patients. And so those 2 distinct areas suggested was an opportunity for us to work on. So today I'm going to introduce a short amount of content based on some requests from the field to talk a little bit about sustaining and spreading change and how do you do that. And then we're going to dive into asthma. We have a little bit of data. We'll talk about what more data. And then we'll do a little bit of an environmental scan and try to pull out of you what assets and resources exist in the environment we might be able to leverage. And then talk about some next steps as we plan for moving into December and January, February, what we might do with asthma. So I'll come back to that. So let me start with talking about sustaining and spreading change. Leading, sustaining, and spreading change is probably one of the most challenging things of senior leaders, one of the most important roles that we can play. It's also one we take for granted. One of the traps of leadership is that we believe the traditional hierarchical model where we cascade information down through the organization result in change, and result in people getting the message. I was with a group on Friday, and they have a relatively new email system that they put in, and they have a weekly newsletter that they send out to the organization to give updates. And I got great feedback from the staff on this weekly newsletter. But when they actually look at the data, less than 50% are opening the email, right? And people are saying, I didn't get the message. Why am I not getting the message? Well, that was their principal way of just cascading down through the organization. So really understanding, how do people really learn? How do they adapt change? How do they move forward is what we're going to be focusing on. So one of my profound lessons came in this needle stick example when I was a hospital administrator in the 80s. I was walking down the hallway of my hospital, and there's a nurse crying. And I said, Jerry, what's wrong? And she was one of heart and soul of the organization. She said, I'm quitting. I can't take it anymore. I said, what's wrong? She said, I'm on 5 needle stick committees. We were a regional aid center with the outbreak really just hitting. And one of the challenges is our staff are getting infected as a result of needle sticks. So it was a really, really serious incident. And I said, 5 needle stick committees? You mean you're at your 5th meeting? She goes, no, there are 5 committees working on this. I staff them all. I can't take it. I'll talk about the same thing. Blah, 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 blah. I said, this is ridiculous. It's over. Tell me what the solution is. She said, we need needle boxes in every patient room. Jerry, it's done. Call up my plant manager. I said, this is like a Tuesday. So by Friday afternoon, I want needle boxes in every patient room. They were up in every patient room by Friday afternoon. What happened to the incidence of needle sticks in my hospital as a result of that? Went down, skyrocketed. They installed these opaque red boxes, put them up too high on the wall. More people were sticking themselves, putting the needles in the box than our practice. I also added $25,000 of operating costs to handle this new needle box program in the organization. And I said, how can this happen? And then I started learning a little bit about how change actually happens in organizations. This is the famous Everett Rogers diffusion of innovation curve. Now, change is a process. There's lots of people, lots of theorists out there that have described change. Kotter out of Harvard, and Oski, and Kurt Leuven, and others. But they all suggest that change is a process, and we in leadership forget the process steps. Kurt Leuven has a wonderful model that he talked about, that in order for there to be change, you first have to unfreeze people. You can't just go plot change on people. In fact, one of the key drivers of intrinsic motivation, which is a sustainable motivation, is the ability to control the variables around your life. When change is imposed on people, they push back. And a lot of it is because they fear the unforeseen consequences of what change is going to bring. They don't know what this is about, where did it come from, and it's nothing but bad news for me. And we see that with our care teams. We put on new measures. We have alert fatigue with our EMRs, where we're constantly dumping more and more on our care teams. And the care teams are pushing back saying, I've had it, I'm in overload. You know, what is this all about? And a lot of it is out of context. So you have to first unfreeze the change. The second is that you have to then give them new tools and methods of what to do about it. And be very specific about the change you're trying to make. And the third stage of the change process is refreezing. Make it very difficult to go back to the old way. So that's a pretty simple model to think about. What do you have to do to unfreeze, create the tension for change? What do you have to do to give direction? And then what do you have to do to refreeze? Now, I wish it was as simple as a model like that. But the reality happens is that change is a social process. And there's a lot of evidence about how change takes place in the environment. So from the time a change is offered to an environment or system to when it hits the midpoint of being accepted by the environment, 14 to 17 years, according to the original research done by Everett Rogers and validated by the Agency for Healthcare Research and Quality in Healthcare, by Deloitte Touche, by others. So when something appears in JAMA or New England Medicine or some new therapeutic comes out, the time it comes out when it hits the mainstream takes about 14 to 17 years. Then all of a sudden it takes off like a rocket. So there's been studies to figure out why is that? What is actually happening that is causing this kind of crazy phenomenon? And what they found is this diffusion curve. And many of you have heard the term the early adopters, you know, go after the early adopters. Well, Everett Rogers studied the introduction of seed corn in Iowa. And they had developed a new seed corn that was drought and pestilent resistant, had a higher yield of corn per acre than any corn before. So they introduced it in the community, and then they waited to see how long it hit the mainstream. And at 14 to 17 years, it just was growing like this, and all of a sudden it took off. But there were a handful of farmers that never changed. And they went and talked to those farmers, why won't you change? And they said, well, you know, this seed corn's been in my family for hundreds of years. We're not changing. This is our seed corn. I don't care what it does, you know, it's not that important to me. What they found, though, is that when you hit the early adopters, there's a group of pioneers that introduces the new idea, the change. Some of you are pioneers in your environment. You introduce a new change. The challenge with pioneers is often they're looked at by their peers as whack jobs. They're looked at as these, you know, strange folks. I'm affiliated with Hopkins, and we have a couple of real whack jobs on our faculty. One guy's been living in his office for 30 years. Lives in his office. That's his home office. A brilliant hematologist. But one strange guy. Okay. Tremendous bench research coming out of his lab. New approaches. Wonderful. Right? Everybody looks at him like, wow, he's out there, right? There's a group called the early adopters that are the ones that are always looking for competitive advantage, looking for one step up, one way to get ahead. And they watch what happens with a new innovation, and they usually calibrate it off of someone else using it. And once they convince themselves, then they start using it. That makes up about 13.5% of the population, the pioneers of the 2.5%. So it's about 15% of the population total. If you can get 20% people using the new approach, the new change, and it is almost impossible to stop that change from hitting. And that's where you see a hockey stick takeoff. So you'll see in this slide, there's a long progress here, and then all of a sudden there is a hockey stick explosion. This was in the adoption of the chronic care model introduced by Ed Wagner and his team at Group Health of Puget Sound. They introduced that back in the early 80s, and it didn't hit the mainstream in primary care. It still hasn't been fully adopted across the environment in the 1990s. Now, the implications of this on change is we spend all of our time trying to convince the traditionalists, those laggards, those four farmers that said, I'm not using that corn. And they are often their leaders in the community. They're often people whose opinion people respect. Oh, Charlie's been around forever. I mean, he knows how to farm like crazy. I mean, you better pay attention to what Charlie says if you know. If he doesn't like it, there's got to be something there we ought to think of. So in leadership, we spend all of our time trying to convince the naysayers. And it's emotionally taxing. It takes a tremendous amount of selling. And in the end, they may never change, never buy into it. So it keeps us from moving forward. So what the lessons from this are, if you can focus on those early adopters and burn in your change, start with one early adopter, and then go to the next early adopter, then go to the next. You will accelerate your change to the point where that becomes the mainstream way of doing it. And then you can put in the long-term sustainable pieces you need, policies, procedures, other things that go along with that. So an example of that, I don't know how many of you have written policies and send them out to the organization, and they're giant belly flops. And we usually have not tested the policy. We have, just like my noodle sticks, we didn't test on one unit to see if it would work, the bugs. You do this broad shotgun, and then when it doesn't work, we spend all this time trying to convince the resistors, and eventually we just often give up. Lesson is to start with the early adopters. I'll get to your question in a second. Burn it in, and then put your policies in. Question, Dave?
That sounds terribly crass or whatever, but assuming we believe in evolution, why don't we let the traditionalists keep doing the way they do it, and then let them go out of business, or let them be shut down because they're dangerous to patients or whatever? Because some of this stuff is actually patient safety.
Absolutely.
And they refuse to do something different. Don't try and convince.
That's the point.
That's pretty harsh, but
You got the point. The point is, don't do that. Don't waste your energy. The point is, make it work with the early adopters. Make it become part of the mainstream. If it's a real patient safety issue, you have to do a risk management calculation as if they continue that practice, is it going to compromise the organization, therefore a change needs to be made? Or is it not really a risk issue, but it's, you know, they will either commit euthanasia, let them die off, is the bottom line. But put your energy into those that are willing to try it, willing to make it work, willing to burn it in and learn from it, study it, burn it in, and then you're going to find that your pace of acceleration is faster, and your personal anguish is going to be much less. Not having to convince
I
it.
realize that I'm not I'm an early adopter. So it's easy for me to make some changes and all that kind of stuff. I think sometimes, and I'm not speaking about North Central Washington, sometimes we spend a lot of money in organizations on ventilators and giving them one-to-one nursing care, all sorts of stuff. I just got back from a trip to Oregon. And this is what's happening down there. And I'm not trying to say that the communities this place serves, it's Central Oregon, and I'm not going to say too much more because maybe everybody knows communities there, but resources are being spent trying to make the people with the 100-year-old seed do something different, and maybe you just need to bypass it and give them the information, and then if they refuse to change, yeah.
I'd like you to reserve that thinking when we get to the asthma discussion. So, you know, where are the opportunities for us to influence the environment in asthma and apply those same concepts? Let's not go convince the whole world about what we need to change, but let's go find where there could be some real tests of change that could really influence the numbers and see what we come back to that. Some of you heard Malcolm Gladwell has written his book, and he talks about the tipping point. Well, that tipping point is that curve he's talking about there. It's that early adopter curve. And what's interesting is Gladwell talks about what he called mavens and connectors, right? So there's a company that was bought by Aetna, one of the large insurance companies. It was called ComSort out of Baltimore. And what they did is they mapped every physician in the United States and identified who the mavens and connectors were. So they literally called physician practices and said, who do you talk to if this new antibiotic comes out for kids? Who do you talk to bounce the ideas off? They usually have a subject matter expert, the faculty from their medical school or someone in the community, and then one other colleague they really respect to bounce the ideas off. And what the pharmaceutical companies found, you mapped those mavens and connectors and did your detailing on those folks, sales skyrocket. The early adopters. If you get the early adopters on board and that next group, boom, it takes off like a crazy. Now, in our quality improvement efforts, one of the things we're teaching teams is knowing when to scale your PDSA cycle. This is really, really important for those of you that are guiding improvement efforts in your organizations. All too often, someone will have a winning PDSA. His leaders say, okay, we're going right to scale. Let's just burn it in. I'm sending out a new policy. It's not ready. It hasn't been baked in. It hasn't been tested enough, different conditions to see what's really needed. So we want to see the degree of belief that this change will really stick. Have we tested it in different shifts, different environments, different sites, different conditions to make sure that it's going to work over time? Each of those has different nuances we need to think about. So when a change comes out, if we have a very high belief that this is something that we can scale very easily, sometimes there are things that are no-brainers, especially in a patient safety area. I think the last time I was here, I talked about a client, a hospital system that had a sentinel event resulting in death due to breakdown in process with a patient in the hospital getting food that they were allergic to and coded. And they did a RCA, root cause analysis, right that day, the next day. Behold, a week later, they had another incident. And it didn't result in death, but another incident. They hadn't put in the changes they need. If it's a serious issue, like you were suggesting, then sometimes you got to go to scale. But you have to have a very high degree of belief that you're ready to do that. So this notion of different beliefs of where we are versus the level of commitment of those in the organization. So if you have a real easy change that is intuitively makes sense to people and there's good, strong evidence, tested and it really works, you have really good buy-in, then that's something you might be able to go to scale. But if you haven't tested that buy-in and pushback through that early adopter approach, then you're likely to run into some buzzsaws of that resistance to change. Very, very important to step back and look at what we could do. So the first piece of the puzzle is, before we spread, is have we put the systems in place to sustain the work? Okay, so you have a new process, a new approach. We're going to test this new care manager role on our care team, or we're going to do this new social determinant screening tool with our staff. And we think the front desk person can implement it. And we've had pretty good success in one clinic with one care team doing this new tool. So that's great. Let's really see how that works. Can we test it now to another care team? Can we test it to another area of the clinic? See what challenges are. It may be all a function of the superstar that's putting it in, but it may not be something that's real easy for others to do. You've got to test it enough to get to the point where you have confidence. And then the question is, what systems do we have to put in place? One of the challenges often in quality improvement is that we start a project and we don't think of the long-term sustainability, and we don't put the reliability systems in place to ensure the success. Cedars-Sinai I do some work with, and they a meeting with them recently, and someone asked, when do you end projects? And they looked and said, end projects? We never end a project. If it's important enough to start a project, then it's sustained forever. When a project's over, we assign an owner, someone who's responsible for monitoring that process and owns it. And they're going to look at the data long term, and if it starts regressing back to its normal steady state of mediocrity, they're going to jump in and say, we need to make some changes. We need to make sure that things are in place. For those of you that are accredited by the Joint Commission and others, there's a real focus on reliability theory, high reliability organizations. This is all about the practices of what are we doing to make sure that these things are staying fixed. There's long-term measurement in place. It doesn't necessarily need to be on the corporate dashboard. Maybe it needs to be at the point of service, someone owning it. So if you're working on cycle time in your clinic, often we'll get these huge gains in cycle time coming down. and then we celebrate, and then 9 months later, staff are coming back going, we got a problem with cycle time again. It's like, well, we just worked on that. Right? Well, then it turns out nobody is looking at it on a daily basis. No one is owning it, and no one is making sure that it's staying fixed. So you want to make sure that there's an owner for every process. You have a measure in place. You want to make sure you have all the administrative systems, the training, the collateral material that you need, any changes to job descriptions, any of those bureaucratic administrative processes that are necessary to put in place. Then you have to have the system of monitoring compliance. So who's going to do that? Again, better done at the point of service by local staff, giving people a sense of ownership for it. And then where possible, make it very difficult to go back to the old way of doing things. So organizations that put in new electronic record systems and had electronic forms and paper forms, or maybe you're making a change to a form, and you've got a lot of the old stock. People say, well, we'll keep both forms in place if we run out of the old one. Sure way to kill your adoption of your new process. You want to take away the old form and make it very difficult for people to go back to the old way, right? All too often, we're worried about that change process, but not thinking about the long-term pieces. Any questions on sustaining the gains? Any questions on that? So keep in mind that change is a social process. This is a model from the Institute for Healthcare Improvement. And what it suggests is that if we have a new change, a better idea, a new process, that before we spread it through our social system, we need to be really paying attention to the setup. Who are our targets for the next early adoption phase? Where is the evidence base we've created that we can package and show people the impact so they can see that it's observable? Do we have an initial spread strategy? We're thinking through who are those next 2, 3, 4 targets are so that we can make sure that that process is in place. This is an assessment model developed by a fellow down in Miami, St. Anthony Amofa, who was with the community health center down there. And he said what he suggested was that in his organization, they do a pilot team, and they then make sure that they've thought about the alignment with the strategic plan so they can connect the dots for people in the organization. They make sure measures are in place. This was in the case of putting a registry or database in place. Are there staff to support it? Is it going to be sustainable long term? Is that built into the budget? Is there a senior sponsor responsible for overseeing the change, making sure it's staying in place? And they do a little bit of failure mode analysis. Where is it likely to go wrong? What distractions are going to come up to keep this from putting in place? So if you know you're about to have an external accreditation review and you're then about to put some changes in, that could be a deal killer. As soon as you're launching it, all of a sudden your accreditors are arriving on site and everything's distracted and people are forgetting what the new changes. So really thinking through the timing of your changes. Leadership's role, one is to make sure that your topics that you're working on and prioritizing are in alignment with your strategic initiatives. Do you have a senior sponsor assigned to oversee the change, make sure it moves through the organization? Is there a frontline day-to-day manager identified for a change that you're trying to put in? And are your goals and incentives aligned in the organization? So are there any of the performance feedback or reward and recognition that would align, support some of these big changes you're trying to make in the organization? As you're planning for spread, you should be thinking about that as a design process. Don't take it for granted. Who's your target population you're spreading to, your next provider, your next panel of patients, your next clinic? Was your pilot successful so that if they turn back to the other group and say, well, how did that change work? They could say, wow, huge impact. I'm getting home on time now every day. You should see the numbers that improve for my patients. You should see it's reducing cost. Whatever those metrics are, that they have good, strong evidence. And then really plan who are those early adopters and the initial spread strategy. And try to be thinking through as systematically as you can how you're going to spread it. And looking at patient-centered medical home, let me give you a couple examples. One organization created a pilot team that was applying all the concepts of patient-centered medical home or health home. And that pilot team served as the spread group. And they went care team to care team as a group going and explaining to their peers. So the front desk person explaining to the front desk person, care manager to care manager. physician to physician. These are the changes. This is how we're doing it. They're going on site, an opportunity. Another group created the spread clinic where they have their new best practices and invited early adopters in to follow them and shadow them to see how the new workflows will work. This is what the care manager does. This is what other people do along the process. Another organization has a simulation laboratory, and they use that to burn in changes. So they actually do walkthroughs with people to see how you can do the effort. So different approaches, but in each approach, it's a social process. It's getting the staff communicating to the others, packaging the information, targeting who to spread, and then really monitoring, moving it through the environment. Being sure to create the context for why the change is needed, not just plopping the change on people. So you'll notice in the earlier, we talked a little bit about the start of this, and I created a breadcrumb trail from the prior meeting, connect the dots for people. That's a really important function in leadership, that we connect the dots of why we're doing what we're doing. Makes sense to people, create that context. Take advantage of your existing relationships in the organization. You can pretty much map already your early adopters in your organization. If I were to ask any of you, who would you pick for this particular project or initiative? You'd say, oh, I could tell you exactly who. This is the person I would go to as an early adopter. So map those early adopters and look at how you can burn in the change to them. And where possible, we heard here about how these learning and action networks are creating communities of practice, that social benefit of learning from others. You can do that intra to an organization, especially if you have multiple sites or multiple opportunities, multiple care teams. So creating that opportunity for them to collaborate, share with each other is part of the power of the process. Let me stop there and see what questions there are on spread. Any questions or comments on spread? Any great belly flops to share on spreading? I have a whole list I could probably share.
We've got all kinds of belly flops. It's hard. The why, I think you didn't probably emphasize that as much as I think we found the importance of why, explaining the why early on, to get people to do things. Because you try all these carrots and sticks to do things, and really it's internal. If they understand and buy into the why, it's so much easier.
Very, very powerful concept. We have, our leadership systems have been trained over the years to focus on extrinsic rewards, punishment, or carrots and stick. And we think that's going to be the reinforcer. It's going to make it happen. The evidence base is there's yet to find a single study anywhere that shows how extrinsic rewards lead to long-term sustained performance. They're all based on the Skinner rat and Pavlovian dog experience. Okay? And people are not dogs and rats. Fear and extrinsic rewards work short-term. The problem is you have to keep applying them, and they have an attenuation effect. You have to increase the intensity over time. So when you throw out an initial pay for performance or reward, next time people are saying, well, it's worth a little bit more money than that. I'm not sure unless you get a little bit more. It doesn't have the same effect. As David said, it's really the intrinsic motivation you're trying to bring out. And part of that is the why. It has to make sense to them. It has to have some value and meaning. It has to be connected to a greater good. Want to make a comment on the phone?
This is Doug Wilson. Can you guys hear me?
Yes.
One thing I notice is that we at Confluence particularly have such a proliferation of initiatives, and also I guess what I'd say is the ecosystem that we providers live in is changing so quickly. The EMR is different than it was 6 months ago, and so these projects not only need to be sustained, but they need to adapt with us and continue to become more and more usable and less burdensome, rather than the default, which would be that they become more burdensome and obsolete because everything else in our practice environment is changing so quickly. So I think it really requires determined focus on making sure these important projects stay relevant and usable.
Great observation. So one of the key things from a leadership perspective is to make sure your projects are relevant. We have lots and lots of projects that we've piled onto people. Some of them feel like appointments for life. You know, they're working on them 3, 4, 5, 6 years, and they're not making progress. Highly recommend you consider committing euthanasia for those long-term projects that are not making progress. Kill them.
Absolutely.
Start all over. Staff will really, really appreciate that you're not wasting their time, and find a new group that may have the energy and different lens and perspective and execute on it. Secondly, you know, if we do have a lot of projects, sometimes the environment forces us that we can't do things in a linear fashion. We have to do many things at the same time. The more you can democratize that and pushing it down and delegating it, supporting it, rather than putting it on the shoulders of a limited few in the organization, then you can really scale in a much more concerted effort. But it requires tracking it, requires having a senior sponsor assigned to it, having the good metrics you're following, and a communication system that you're feeding back so people can see that all this change is heading towards a better state, that we're actually making a difference here, that we're moving things forward in a better way. Other comments or observations?
I get what you're saying about the change, and how does that relate to really tiny organizations? When you only have 4 people doing whatever it is, you can't switch and move and, you know, either do it or you don't.
Literally.
I mean,
So one thing is suggested earlier is look for things that are not adding value and can you get rid of them. Are the things that you're just doing that are just not having the impact and value. And then they're not connected to an external need where you have to do it for accreditation or licensure or whatever, but something you've imposed on yourself or the team. A good example is frequency of meetings. Over and over and over again, every organization I go to, we have too many meetings. You want us to do all this work, and 80% of our week is in meetings. When are we going to find the time to do this? All right, can you cut your meetings in half? If you're having a weekly meeting with a direct report, do a content analysis of that. What percentage of the time is value added? Put it every 2 weeks. You freed up an hour a week. If you have 6 reports, that's 6 hours a week. And now in a small organization, you don't have a lot of direct reports. So is there any work you can get rid of? 1. 2, how can you start to take your work and boil it down into a series of sprints? Create a parking lot of things to do and focus on a small number and execute them brilliantly. And then pull out of your parking lot the next one and execute. What we do is we just add, and then it's so overwhelming, and then we don't execute any of them brilliantly. So if you can focus your energy, then execute. Notice the very large companies, Hewlett-Packard, Microsoft, Apple, they're coming out with one blockbuster product a year, one major new upgrade. They're not coming out with this Sears catalog of products for you. Sometimes it's a couple. They focus. They put tremendous amount of resources on executing brilliantly. By the time they're ready to launch, they've already field tested it with people. They've already fleshed out how our early adopters dealing with this. What are the prospects of being able to go to scale with that? So take those same concepts. Let's focus on a small number of priorities, execute them, create them where possible into sprints, and then move on to the next one. Find that your pace of execution will increase, and it'll be less overwhelming for the collective team. Does that help? Yes, ma'am.
What about pausing? So this is always moving forward. Have you ever experienced where it's advantageous to just say, we're going to stop and not change anything for a little while?
Yes. That's a function of where the organization. One of the things organizations often don't do well is stop, pause, and celebrate. Acknowledge the progress, reflect on where we are, how is this having an impact on what we're doing, and recharge the batteries and set the next planning horizon. So where possible, moving your work life into a series of targeted work over a specified time, and not just this open-ended, never-ending journey. Then pausing, reflect, take a break, take a breather, review the measures, review where we are, celebrate the successes, do some failure mode analysis. How are we building sustainability? And now let's work on the next activity or next sprint. Does that help?
Yeah, thank you.
Any other comments or questions? Make the offer. If you have any individual circumstances you want to shoot me an email. I'll be happy to have a dialogue or do any individual coaching offline.
Roger, can
Yes.
I say something?
Yes, ma'am.
I think one of the things maybe we worry a bit about as an ACH is that in creating a change plan, and I'm just being honest and transparent, just to like recognize dynamics of the change plan, it is adding a lot of things, right? So what you just described of like adding, I'm like, well, okay. Some people might be thinking that that's what we're doing with the change plan. So how do we help? And I think, you know, that's one of the reasons we want to develop a coaching network, is to provide more support to help organizations pause or help organizations take smaller chunks. But do you have any advice around the change plan, around sequencing or starting small, just so that people don't spin their wheels and that we as an ACH don't contribute to failure because of being overwhelmed?
Yeah, absolutely. So, yeah, and I think a key in with respect to the change plan is, how does it align with work that you are already doing or intending to do? There's already an existing body of work that aligns, and you have been able to piece together that messaging staff so they understand the strategic importance. That's one piece. Sometimes we're doing the same thing, but we label it a little bit differently. You want to make sure that it's in alignment. Then secondly is being very clear on your priorities and taking that pulse and temperature of the organization on how we're doing. Where possible, spreading the work across multiple pods or entities in the organization and not hurrying one organization. Not scaling too fast all at the same time. So going after those early adopters, letting them burn in and test, and then letting that spread through the organization through that guided natural process, rather than instant scale. Okay, what we just learned out of this behavioral health plan, we're scaling to the whole organization. That's going to be probably a belly flop. It's going to be a challenge unless you really plan. How are you packaging? How are you aligning it? How are you connecting it to the why, the training program, and what's the spread target? So a combination of priority setting, alignment with existing, and carefully connecting the dots so people see the value, and then feeding back, how is this connecting to our dots moving as an organization? Are our overall measures improving? Our cost going down? Whatever those key metrics are. Hope that helps.
Even CACH is really also setting the pace too, that if you look at the future of where healthcare is, we have to have measurable goals. There's things that we've done that burn a value, and that without having specific targets like this, then we are moving forward. What he was talking about is that there are things that we've done that have been on ventilator and now we're really targeting our goals, those things that really have specific target outcomes, but also that are really identified by what the disease.
So let's use that as a segue to apply this theory to asthma. So after the last meeting, we spent some time on the web looking at what data are available for your 4-county region. That would be a starting point in the environment. So discovered that there's a statewide asthma plan and that there are some data. Unfortunately, the data are old. It either goes back to 2008, 2010. So that's 7 or 8 years. You know, there's an old saying that all models are wrong, most models are useful. So all data are wrong, most data are useful. So there are some data that are presented here. I want to have 2 discussions around the data. One is, did you learn anything out of this data? Anything stand out? There are a couple things that stood out to me, but I want to hear from you. And then 2, what data do you have available that can help inform this that might be more current? Where can we get some current data that'll help validate our planning assumptions and priorities? So for those of you that had a chance to look at the data, anything stand out for you? Anything pop out of the data? I'll go through the slides quickly. You'll see there's color coding. So the darkest color is the highest prevalence. So this is adults with current asthma by county. So Okanagan has the highest, and Douglas. Chelan and Grant are lower color.
I think it'd be interesting to throw in average family income, because as a rule, rates of smoking, obesity tend to be higher for lower income. Maybe I don't know, but if Okanagan, seems to be the worst off, also has the lowest, maybe that's the correlation we should be looking at. Maybe not so much doctor's offices, but social determinant kind of stuff.
Yeah, we could spend a lot of time beating up our care teams on following the latest asthma guidelines, and we may be missing the point. I was in Louisiana last week with the Secretary of Health, and they have a statewide colorectal screening initiative and breast cancer. And she reported to the group, she says, we have the worst incidence in syphilis per population right now. It's exploding. And people say, well, where do you even start with that? And she said, you know what it comes down to? 90 women. That's something you can do something about. You could put a nurse in a van and with antibiotics and go out and treat those 90 women and shut down the epidemic, right? So it's really important to understand your data and look where you can have an impact. That income would be an issue, and you mentioned smoking. So it turns out cigarette use is also higher in Okanagan. That one has the highest incident. It also correlates with that.
Also, your other counties that are pretty poor counties also almost directly correlate as well.
Yeah.
So income.
Poverty.
So obesity is related to asthma incidents, especially with children. So higher obesity rates. Interestingly, Grant popped up there rather than Okanagan as the leader. This one stood out to me. The Black population having a significant higher incidence than the rest of the population. Now, whether that's sustained over the decade or not is a question. But any insights on why that might be?
I'm guessing that part of the problem, especially in urban communities, is that places where they can afford to live are probably next to smelters and industrial areas and things like that, and the air quality is probably not as good.
Yeah. So in Camden, New Jersey, Jeff Brenner and his group came up with the concept of hotspotting, and they looked at their asthma data and were able to drill down, and it happened to be a very poor African American community. When they looked at it, it all circled around a couple of housing units. And when they went into the housing units, there was mold rampant throughout the housing units. So their intervention was to address the mold in those units, either displace the people or fix the buildings up to decrease the asthma rate. So are there any opportunities? Could we geocode some of the data? Can you go back and look at your data, people with asthma, and geocode where do they live? Maybe something will pop up here that just next to a smelter, or there's some other environmental cause that we need to be thinking about. Any other aspects? So we saw the race was one. Air triggers for a series. Particulate matter. Any reason why Okanagan would have, and Chelan would have such high particulate matter? Fires.
That's number of days, right?
So air quality time due to the fires. Now this is 2010.
Probably worse.
Probably worse now. Huh? All right. Here's another one. This is something that is actionable. How many of the patients actually receive information on self-management by our care teams in the system? What we see is that people, how many are getting received an explanation on how to recognize early symptoms, 40% or not. what to do, taught how to use a peak flow, only about 40%. Written asthma plan, 20-some%. So 70-some% are not getting a written plan. That's something that's actionable that care teams could do across the environment. Youth with an asthma plan, 40-some% do not have an asthma plan for those diagnosed with asthma. So an opportunity to engage the family, engage the patient, and trying to figure out what some of the root causes in their environment. What's driving some of their issues. No PCP. So how many patients are coming through the ER? So there's, I think, 20% of youth had asthma at least one ER visit. So if 20% are coming in, how many of them are coming in and don't have a doctor where we could connect them to a potential primary care provider and one of the systems in the environment? To pick up, right, as a larger environment, trying to find ways to connect people. That translates also to a business case for those primary care organizations, potentially depending upon the funding source. Adults missing work due to asthma. So there's a business case there for how many patients are missing work due to their asthma or their children's asthma potentially. And this is an opportunity to potentially engage the employers in the region, especially if there are a workforce that is saying that maybe near a smelter who are having a very high rate of asthma, that could be causing a high absenteeism rate. We just don't have any data right now to know whether that's an issue, but that could be a compelling issue for some of the employers. Children missing school days. 20% of the kids in 8th, 10th, 12th grade are missing school days because of asthma. That could be a metric that we could see move over time if there was a regional effort. So what are your thoughts in terms of data and getting data and what data might be available? Do we have any payers on the phone? Do we have a payer in the room? And she was texting back saying, get me that asthma data as quickly as possible. Not to put you on the spot, but I think the payers are a rich source of being able to look at their data at a macro level. What do we know about where people with asthma? Is there any information? Any thoughts on data that might come from the payers?
This is Vicki Evans from Molina. I think that we can certainly, as long as there's been diagnosis codes submitted, we can certainly pull those. So we can pull data regionally to look at either incidence or follow up in that. So I think we just need to be specific to make sure in advance we look at what the information is a provider or providers or region wants so that we can set up and configure that to pull.
I don't want to speak for Dr. Coldy or Dr. Wilson, but I'm willing to bet that information located in various EMRs are a lot more accurate because trust me, there are patients who are seen for asthma and that's not going to show up in a diagnostic code. I mean,
what do you mean by that, Dave?
I mean, somebody may have come in for something else. By the way, my asthma is acting up. Doctors are so busy, they don't always put in every little thing that they've done, especially if they did it up here. And I think there are more people with asthma, or there are more services provided to people with asthma than are going to show up in the in the build information.
So there may the claims data may not be as sensitive as the EMR data, but both could help inform if there's some hotspotting or something that we find there's clusters of people even through encounter data. So we could get both. That would be helpful.
Now he's going to say disagree or something.
No, I think you could actually extrapolate that to everything in medicine. Every problem.
Yeah. One thing I think is the fidelity of the EMR in terms of the sensitivity for picking up what's going on in the room is not that great, David. I think you're right on. And that's one of the arguments for using scribes and things like that to actually improve the accuracy of the coding and documentation of what's done, because a lot of times you're dealing with so much you just can't write it all down or remember what you did. It's a big challenge.
Would it be feasible to ask the participants in this room as a homework assignment to go back to whatever data you have available in your organizations and look at your population of patients and see what the data tell you in terms of who are those that have asthma? Where do they live? Is there any geocoding possible to see whether there's clustering of the population in certain areas that might give us a hint of some potential hooks of where we might be able to do some intervention? Is that feasible?
I'll find out.
You'll find out? You're willing to at least find out?
I know we can pull some questions out, but I just don't know about the asthma.
It all really has to do with what question you're asking. Are you asking how many do you have? Most people probably could figure out how many patients they've treated with asthma in the last year. Say, you could define the question, but maybe the more, there's other questions, that we get into where do they live or our zip codes are so big that doesn't really help much. But it may be what time of year. If all the asthma exacerbations are showing up in July and August when the smoke is elevated, particularly high, then do we do an action plan around what do we do in the summertime? Asthma exacerbation. But you have to know what question you want to ask in order to pull the data and just find out whether you have data to pull.
So if we circulate a question set to start,
sure,
and people can at least take a crack and see what's available. If you can't get it, you can't get it. With the collective resources in the room, we should be able to start to get a picture and some insight. And for those on the phone, you're not left out of this. We should be able to start to see a little bit more fidelity in terms of what are the real issues of asthma in the region, and see what we can find from that. Does that make sense to the group as a starting point?
I would think employment would also be an issue. In looking at the particular matters for Okanagan, I'm thinking immediately of the orchards where they're dealing with dust and pesticides and things like that probably have an impact on that.
Our numbers might have improved now that Alcoa closed, because my son-in-law developed severe lung problems after working there just 6 months. Breathing problems. Now it's permanent.
One thing I'd consider doing is looking at albuterol prescriptions or refills, because one thing I notice a lot is patients who have undiagnosed asthma that's being treated without being thoroughly documented.
Okay, that's great.
Except for how often are albuterol given for URIs acutely? Just,
right,
over that cough and you're using it for one time only.
Right, that's why I said maybe look at refills.
Yeah.
Okay. All right, we'll put a question set and circulate it. One thing I wanted to introduce for a future discussion, this hopefully are going to lead us to starting to narrow down where might we make some interventions. Now, in the handout we sent ahead of time, I had collated a set of change packages in the environment of what others are doing to try to address this. So some tangible things that could be done. I'm not going to go into these today, but I do want to offer you hope that this isn't an abstract exercise, that there are groups in other environments that are taking tangible things, working with payers, working with hospitals, working with clinics, working with community providers, all trying to address the issue. But I did want to spend some time today, and we'll come back to those change packages, is to talk about a strategy map. And I'm going to stand up and use technology here. I'm going to ask you, I'll go through this real quickly. I'm going to ask you, is there a, well, let's do, sorry. So this strategy map is work that was done on obesity, I believe, in San Diego. And they've outlined a target population. It's kind of difficult to see. But in this, they have taken the major stakeholders and outlined some specific initiatives of what could be done. So for example, Mayo had some great success in addressing asthma by working with nurses in the school system. And we're really the primary contact with the students and helping them self-manage and getting kids on medication and elsewhere. So engaging the school systems as part of the effort is an example. What I'd like to ask you is what community assets exist out there that as we move forward, we can start to catalog and build together kind of a coalition working on asthma in the community to move those numbers up. So what resources exist in the community that might be leveraged or should be brought to the table to start to influence the environment around asthma? What comes to mind? I mentioned schools.
Joanne Douglas helped us.
So public health for the 4 counties, that they may have interventions and things going on that already could be leveraged. Schools might have programs already going on.
What about the pharmacies? We could look at the number of refills for albuterol.
So actually reaching out to the pharmacies or the pharmacy chains to see what data might be available. What are they doing? Are they providing any education as patients and families are coming in?
Who controls the burning ban?
The burning ban?
Burn stuff.
Do they have an
EPA
air quality control office in town?
Terrible. Welcome back.
Air quality control office?
I used to have a PE teacher that called them every morning to complain about the smell. That was an everyday thing.
Other thoughts? Who else is in the environment to bring to the table potentially to start to look at who could really come and leverage the existing resources, knowledge, information, activities to influence asthma in the environment?
I'm not sure who manages our smoking cessation plan.
I would say smoking cessation.
Right.
Any others? What comes to mind? Anybody on the phone? Any resources in the environment?
Somebody who's really passionate about reducing asthma symptoms. I mean, I don't know who that would be, but that's, you want to get somebody to get everybody jazzed about this.
So your story is an example, and you talked about your son, and there was a little bit of passion in your statement that this had a real impact on my family, right? My son working at this plant. So those kind of stories that can really connect people to the why.
What about
David was saying.
coaches and people who lead teams?
Part of that's through the schools, but also through Parks and Rec.
Parks and Rec, so
Yeah.
Any others?
This is Ramona in Grand Coulee. And one of the things that that we have here is a number of people who do not have any other source of heat but wood burning. And so I don't know quite where that would fall into helping people find more efficient wood stoves, better air circulation. Some of them, we have a high level of poverty, so even having electricity is maybe very iffy proposition. That's most people heat with wood, so that's another area of concern.
And we're not eliminating the healthcare, like emergency rooms, primary care. I don't see any of us on there, but.
Yeah. And we've assumed that the delivery system, ER providers, primary care providers, all of you in the room, will be working on this and figure out how to leverage that across the environment. Other stakeholders that come to mind.
MCOs, public health, or public housing.
Public housing?
Yeah,
Oh, yeah,
like
housing
mites and cleanliness of the areas and dust.
MCOs.
MCOs, yep. Anybody else that comes to mind?
Employers who might be impacted by losing them.
Yep, employers.
Days, you know,
Our stats affect the economic development portion too.
So Chamber of Commerce or some groups like that? So in the interest of time, what I'm going to suggest is that we start a landscape map, strategy map of who the stakeholders are. We'll ask that if all of you can go back and do your homework on what can we learn about asthma of the populations you serve, what data you might have available. We'll start a question set to get that out to you. Ask the MCOs to see if they can help us with looking at data for the 4-county region and what do we learn from those populations. Is there any clustering? Is there anything that attributes, demographics, or anything that stands out from a population health perspective? The next step also with the strategy map will be to reach out to these various stakeholders and see what programs are in place. Are there things that they're already doing? The MCOs might have materials they're giving out to their patients on managing asthma. Those of you that are providers also may be giving out materials. So and what exists already, we don't have to reinvent the wheel, that might be able to be leveraged. And then looking at other environments, are there interventions that we might be able to address? You mentioned wood burning stoves. There's a initiative that was done in South Carolina where a group got together in a coalition and they went home by home and addressed sanitation and put plumbing that didn't exist before. And it wasn't on the docket to do that through the state. So they were able to raise the funds and make that happen and address a lot of public health issues. I'll send around a case study in England where a single lady did this and addressed heating in the homes. We were able to get heating into a huge number of homes in a very impoverished area. So what may sound like impossible, actually people have done. So where there's a will, we can leverage that. Any questions for where we are today and where we'll be going next? So next we'll review the data of what comes in. We'll prepare a more refined strategy map and we can continue to build onto that. And we'll start to look at what interventions might be able to be feasible. And that could include some future sprints or lands or other activities of all the providers in the room. See what we could do as a concerted group to move that one indicator. Any questions? Any questions on the phone? And Wendy, I think I'm on time.
You are, thank you. I would add childcare to the list, Roger.
Oh, yeah.
I'd add childcares.
Childcare,
And
yep.
Catholic Charities who does the licensing and that.
That's true. And I just whispered over here, the CHICE, the Coalition for Health Improvement, because those are our boots on the ground partners that might have other ideas as well.
Great.
Good work.
Thank you.
Hold down on this.
All right, so next time we have about 10 minutes to do a quick roundtable. I'll open it up, and if no one volunteers, then I'll just start on my left or my right and go that way. Does anyone have anything they have to share? Burning desire? All right, I'll start with you, Mike.
Oh, great.
Anything you'd like to share? What's going on, or?
I just appreciate the opportunity to be here and learn from everyone. Appreciate what you spoke about today. Helps me in that quality improvement process and model to understand what we're going to be trying to doing in our building. So I appreciate it.
I'm good.
Good?
Oh, I could have said that.
I love it. Chris.
We should hold off for Susan. January 8th is our integrated clinic opening. We're excited to finally have an announced start date and where we're moving with CVCH.
Nice work.
Nice.
I'm good.
Last week, CVCH's executive team went down to Othello, and we were treated royally, not just because we got free drinks at their cafe.
Nice.
But I would encourage all the organizations here to get out of their four walls and spend time in someone else's organization and ask a lot of questions. You know, we learned a lot of stuff, and I think the land is great, but sometimes just physically going to someone else's place and asking questions and learning things, and they're asking you questions, I think that's a positive thing.
Thank you.
Say the behavioral health and the primary care land has, been a venue or a mechanism for prompting some forward movement, in our behavioral health collaboration with our pediatrics. And so I really appreciate that.
Ollie?
And in our land, I discovered the swim lane workflow, which I think is cool. Oh, I'm going to say that.
Swim lane.
Yeah, because that way you see, not only do you see the workflow and what happens first and then what happens next, but you see whose plate the work is landing on. And you can evaluate, maybe you need to take some things off of that individual's stuff to do during the day. It was eye-opening.
And that was on the last land, right?
Uh-huh.
Yeah.
So that recording, if you're interested in what she's talking about, that recording is on the portal. You can go and listen to it.
And that's the behavioral health into PC. Okay. Yeah, I'm in the other.
Right.
I just want to say I really appreciated Roger's trainings today, especially regarding the how change happens piece. I think it's really helpful to have that understanding. And I feel like we have a long ways to go in terms of implementing that. But it's really helpful to have that concept to work with. Thank you.
Yeah, I agree. I think that will really help us as we're trying to take what we're learning back to the bigger organization as a whole, because I think that is probably where we've fallen down the most, is having that excitement at the top level and it landing on other people's plate as one more thing to have to worry about, instead of building that up from deputizing them to the vision and the why instead of because we said so. And the other thing too, I think this was really kind of a fun exercise with this asthma thing. Family Health Centers is starting a more formalized wellness program for their staff. And I think this would be a great little mini project I know that we have a lot of staff and their families who have asthma diagnoses. And to be able to look at that just within our own wellness committee to see what we can do that could impact that in a small scale would be a really great little mini project for us to do.
Awesome.
I would just echo Dave. I was there for David and Blake when they came down, and I would just echo his, when you come down, then we also start talking and looking at other things, and we learn from you as well. So I would also echo that.
I'm good.
Just super quick, just to let everybody know, the hub's been up and running now for 1 month, and we have 7 active clients. We've had a total of 132 referrals from the emergency department. The biggest challenge that we have currently is finding these folks, even though they're found in the ER. It's hard to find them when they go back out in the community, but we're working on that. About 20% of them are kids, FYI. And then I have a list of the #1 pathway that's been opened is social service, which I don't think is surprising. Medical referral, medication assessment, tobacco cessation, housing, medical home, immunization screening, and health insurance. So, but there will be a dashboard with data to fill you guys in. And actually, Roger, that makes me think that the Pathways Community Specialists will probably be another good source on that list, because they're actually people going into the home. So I think they'll be a good resource for us moving.
Where do you connect the folks that need tobacco cessation?
I would guess it's probably the quit line. There is no, I will tell you, there is nothing good right now that I'm aware of for tobacco cessation. It's a big issue. It's a big issue.
Anyone in the chairs have anything they would like to share? All right. Well, we are, anyone on the phone? Thank you. Anyone on the phone still there?
This is Rachel. I just wanted to loop back to the discussion on the asthma. I just wanted to let you know that the Wenatchee Valley Chamber of Commerce actually not directly doesn't have anything on asthma, but they are very much looking at the impact of forest health and of course wildfires. So the data that this group gathers could really be informative to what they're pursuing on the advocacy side for long-term, looking at getting us back to a more natural state rather than having smoky seasons 2/3 of the year. So just an FYI, I'm happy to kind of bring back the data to that group as I serve on the advocacy committee there.
Never utilized.
Thank you. Kelm, are you still on the line?
Yes, I am, but I didn't really have anything to chime in, I don't think.
Okay.
You know, I will just kind of reiterate, I believe that was David that spoke about visiting other sites.
Well, I didn't know that was after. But
Not exactly related, but I did go to a roundtable meeting with several of the other community health centers where the COOs get together and visited another site. And I agree, once you put your feet on the ground at someone else's location, walk around, talk about where their people are, what their people are doing, simple things about where they're sitting and who they're working with and how they work together, you learn a lot about other ways to do things. And it is extremely valuable. It's like it's really like a land on steroids when you actually go into the real world environment of some place and pick whatever subject matter it is, whether it's opioid treatment and therapies or whatever it is, and then you just see where they actually operate, how they do it, and have that conversation. You get a whole lot of knowledge real quick. So I'll just basically just wanted to reinforce that is a big plus whenever you can make that happen.
Thank you. Cooley Medical, do you have anything you'd like to add?
This is Ramona. I don't. Thank you.
All right. Richard from Samaritan, I saw you were online. Are you still there? And Mid-Valley. All righty. Well, thanks again for coming.